The United States is in the middle of a well-documented maternal mortality crisis. The most glaring fact within that crisis is that Black women die from pregnancy-related causes at 3 to 4 times the rate of white women. We treat these statistics as established facts, but hospital charts and standard vital records do not capture systemic bias or lived experiences. So we have to ask where these highly specific national facts actually come from. They come from PRAMS, the Pregnancy Risk Assessment Monitoring System. It's a CDC program running for nearly 40 years, tracking the lived experiences of mothers across 83% of U.S. births. PRAMS operates completely outside the standard clinical loop. It is not a hospital survey you fill out in the waiting room. It is not an insurance claims database, and it is not an electronic medical record summary. Right now, this system is on the verge of disappearing. The federal cooperative agreement grants that fund PRAMS participation at the state level are set to expire in April 2026. Allowing these grants to expire effectively unplugs the only national network we have that looks upstream. It is the only tool that can see the conditions that lead to a mother dying before she ever reaches the hospital doors. Letting PRAMS expire is a deliberate choice to stop measuring the problem. You cannot fix a crisis you refuse to measure. To understand the gap PRAMS fills, look at what vital statistics actually record. A birth certificate captures strictly demographic and clinical data at delivery. It tells you what happened, but these administrative fields are completely blind to the systemic forces that produce that outcome. PRAMS bypasses the administrative record, sending surveys directly to mothers to capture their experiences across 3 phases: preconception, prenatal, and postpartum. This records the invisible forces that charts miss, like housing instability, domestic violence, unscreened depression, and critical gaps in insurance coverage. In public health research, PRAMS acts as the essential denominator. It provides the risk factor exposure data that researchers and maternal mortality review committees use to understand why these tragedies happen. But PRAMS exists in a structural trap. It is funded as discretionary public health surveillance, not as a permanent protected entitlement program. Because it relies entirely on federal cooperative agreements, the system is perpetually vulnerable. It requires active renewal, leaving it highly exposed to political deprioritization and standard budget cuts. When population-level surveillance disappears, the damage happens in 3 steps. First, the United States loses the ability to identify emerging health threats early. We won't see the trends until they manifest as reactive, full-blown clinical crises in emergency rooms. In the past, PRAMS data made specific, hidden threats visible. It documented the alarming rise of opioid use during pregnancy and exposed persistent, systemic gaps in postpartum depression screening. Second, the government loses the ability to evaluate policy. When new interventions are launched, policymakers will be flying blind, unable to verify if they actually work. This chart shows the exact risk we face with policy tracking. If a state expands Medicaid postpartum coverage from 60 days to 12 months, the loss of PRAMS means there is no data to prove whether that expansion actually reached the women who needed it. Third, we lose systemic accountability. Advocates rely on this data to prove that disparate impacts exist across different racial and economic groups. Without active surveillance, community birth workers and doulas are stripped of their empirical backbone. It becomes nearly impossible to prove systemic disparities in a court of law or a state legislature without the numbers to back it up. At the clinical level, OBGYNs and hospital administrators will lose the primary comparative data set they use. Without PRAMS, they cannot benchmark their own patient care against national norms or reliably update clinical practice guidelines. The expiration of PRAMS fits a broader pattern. Throughout 2025 and 2026, there has been an intentional federal disinvestment from public health surveillance infrastructure, explicitly targeting the agencies that manage these systems. The financial scale of this decision is absurd. The United States spends approximately $4.5 trillion annually on healthcare, yet the government claims it cannot find the fractional funding required to keep this single surveillance tool alive. The people who ultimately pay the price for this data blackout are pregnant women. More specifically, disproportionately Black, low-income, and rural women, whose outcomes will be recorded, but whose lived experiences will no longer be officially tracked. The decision to defund PRAMS is a decision about what this country considers worth knowing. You simply cannot claim to care about maternal health while systematically dismantling the very infrastructure that proves you do not.